Good morning again. I'd like to thank everyone for coming to this session where we'll be focusing on common health issues in NF1. I think this morning someone made a great comment about what are we doing for the non-tumor manifestations of neurofibromatosis type 1 and how are we improving our care and treatment of the non-tumor related manifestations. So the focus of this session is really to talk about common non-tumor related manifestations of NF1, provide updates on clinical care and future directions with research. So with that, I will give it away to a prepared video that we have from Jessica and Dan Rimberg from the Magical Mila Foundation.
Hi, everyone at the Children's Tumor Foundation and all of your supporters. I'm Jess Rimberg.
And I'm Dan Rimberg.
And we are the co-founders of the Magical Mila Foundation, and we're Mila Rimberg's parents. We lost our daughter, Mila, when she was 17 and a half months old. It was in March of 2019. Mila had neurofibromatosis type 1, and she had a very rare vascular manifestation from her NF. She had mid-aortic syndrome, which meant that her aorta down by her belly button was narrowed to the size of a pencil tip. And she also had renovascular hypertension. So that means that her kidney arteries were extremely narrow. All of the blood in her body was trying to pump through these very, very small vessels. And really, as part of her care, she was checked every few months, as any child with NF is, for just her brain, make sure that everything was growing properly, no tumors, nothing like that. And then as part of her care, she also needed to get her blood pressure taken. This isn't really talked about as much with NF. This is a very important and vital step for anyone with NF. You should always have your blood pressure taken at every single appointment, right upper arm. Mila, it was very tough to get a blood pressure on her because she was, the cuff would squeeze and she would scream and cry. And, nurses, doctors, MAs, they would just kind of chalk it up to, she's crying. It looks high, but it's probably just because she's upset. And we didn't know any better, and we would leave the appointment. And it wasn't until she was 14 months old during a sedated MRI that her blood pressure was discovered, and it was 240 over 110 while she was sleeping. So that mid-aortic syndrome and her renovascular hypertension was detected. We were inpatient at CHOP for 6 weeks. CHOP is Children's Hospital of Philadelphia. Well, they just tried to bring down her blood pressure and tried to control it with medicine. Unfortunately, that wasn't working well for her, and her heart started to fail. So Mila needed a surgery at the University of Michigan, which again was in March of 2019. And it was to fix those two vascular issues. And it was successful. We were celebrating with her. Well, she was not awake, but we were celebrating. We were so relieved. And then there was a setback, and Mila passed away a couple of days later. And I just also want to point out that she had always had high blood pressure. It wasn't detected until she was 14 months. And she also had a sedated MRI when she was 9 months old. But the cuff was placed on her leg instead of her right upper arm, so it was missed.
To piggyback off of that, the blood pressure, her high blood pressure was only detected in the right upper arm, which is where you need to be measuring blood pressure in these young children. Like my wife said, she had normal blood pressure in her legs and her left arm. It wasn't until they actually did it properly that we discovered her high blood pressure. So when Mila passed, we kind of met with her doctors to brainstorm. We knew we wanted to do something, and we just didn't know what that was yet. We know with NF and the great work of the Children's Tumor Foundation, the cancer and tumor aspect of NF1 is really what is out there and what people know it for. But with NF1, it's rare, but kids do have vascular issues. But we knew with Mila's case, since it was so rare, it would have less of an impact if we were just focusing, on the NF1 aspect of it. So at that point, we learned that there's a number of genetic conditions and preterm babies, cardiac issues, whatever, that can lead to high blood pressure in children. So with our initiative called BP Under 3, we brainstormed this with the doctors to figure out, how we can reach the greatest population of kids. So this was launched. We're by year 7. We've raised over $1 million in 7 years. We educated all the staff within Children's Hospital of Philadelphia, the nurses, the MAs, even physicians, on the proper techniques. We host lunch and learns. We tell Mila's story, because every time we go and tell Mila's story, people tell us, we can get a protocol and, we kind of put it in the back of our mind. But if we can put a name to the story and a why to why we're doing things, it really helps us implement. So on top of that, we've gotten blood pressure equipment for the hospital. We've got certain equipment approved for use in kids under 3. And the biggest impact I think we have is one of the doctors on our team who heads the NF clinic at CHOP has said that there's been a huge culture shift at CHOP. And that's, that makes us very proud that people are realizing how important this is and now doing things the right way.
And just to also talk about some of our successes and what we do, we have toolkits that are now in use at all 31 CHOP primary care centers, which is huge. We work with Baxter, who makes the Welch-Allen blood pressure device, which is a device that takes the blood pressure on the way up instead of the way down. So it's a lot more comfortable for kids. We put together posters that hang in every exam room and assessment room in all of these facilities, and mini posters that hang from the Welch-Allen machines, distraction toys so that the kids can get comfortable. And really, we give the staff anything that they need to make this an easier process for the kids. Just the other week, we learned that in Q2 of 2026, so right now, as of summer 2026, hospital-wide, more than 200 children have been referred to nephrology for further evaluation of high blood pressure. So we miss our daughter so much every single day, every minute of every day. We would do anything to bring her back. We are so proud of her and of our team in doing everything possible and honoring her memory.
And our message to all of you is that, with NF1 and other genetic conditions is to make sure that blood pressure is being taken on these children, and most importantly, being taken the right way.
Hi, everyone. That was a perfect video to follow. My name is Dana Mazza. I'm a pediatric nephrologist at the Children's Hospital of Philadelphia, and I have the pleasure of knowing the Roombergs and working with their wonderful foundation, as well as leading the renovascular hypertension program, along with Alex Fairman, our vascular surgeon, to offer multidisciplinary optimized care for kids with renovascular hypertension, including those with NF1. And so we're going to talk to you today about screening, diagnosing, and managing blood pressure in high-risk populations, specifically NF1. So thank you so much for having me. These are just the objectives we'll touch on today. And I'm going to go ahead and get started here. So why do we care about blood pressure screening? As Jess and Dan nicely said, high blood pressure is often silent, and really the only way, often in young children and even in adolescents, to pick up hypertension is by doing routine screening. Early detection and management of hypertension actually has many long-term health implications. It can prevent short-term end organ damage, as was with Mila, with regards to heart failure, seizures, as well as long-term manifestations of uncontrolled hypertension, which in the adult world is called the silent killer because it has long-term negative impacts on heart health, brain health, as well as kidney health, and is one of the leading causes next to diabetes of end-stage kidney disease in adults. So why does NF1 raise the blood pressure, and why is the risk higher in this specific patient population? So as many of you may know, the NF1 gene product is neurofibromatosis. This has a primary role in downregulating a specific cellular system, which often acts as a tumor suppressor to limit overgrowth of certain tissues. However, when you have loss of function of neurofibromatosis, you get cell proliferation or or excessive cell growth and tissue overgrowth. And while we typically think of this as being primarily tumor-driven, neurofibromatosis is expressed in vascular endothelium and smooth muscle. And here is a schematic. This is the kind of wall of an artery. And so if you have overproduction of cell growth within these vessel layers, you can get thickening and then narrowing of the blood vessels, which can lead to, most commonly, renal artery stenosis, or narrowing of the blood vessels that go to the kidney, but also of other larger vessels, such as the aorta, which is the main blood vessel that feeds the heart, as Mila had demonstrated in her video. So hypertension in NF1 has a prevalence of about 16 to 19% of children and adolescents living with NF1. The most common cause, as we've stated here, is renovascular hypertension, which is where you have the narrowing of the arteries. There's also an association with typically benign tumor called a pheochromocytoma, which has secretes hormones that inappropriately raise the blood pressure. This is less common in children, but is reported. And then there's what we call parenchymal kidney disease, or where essentially you can have other tumors within the abdominal space that push on the kidney tissue. This can lead to the kidneys releasing hormones inappropriately that raise the blood pressure. Less common as well, but another reported cause of hypertension in this population. So what does this look like in a basic schematic here? On the right, this is what is referred to as renovascular hypertension. You can see here, this is the aorta. This is that main blood vessel that comes off of the heart. And this is the renal artery, which comes off of that aorta main blood vessel. And so if you have a narrowing of just the renal arteries, this is called renal artery stenosis. Whereas mid-aortic syndrome can happen actually with or without specific renal artery stenosis, where you have a narrowing of the aorta typically at a region that's above the kidney vessels, though it can also be below the kidney vessels. And you may or may not have narrowing of other arteries that branch off of this main vessel that feed the stomach, the small intestine, as well as the kidneys. You can have it on one side, both sides. Every child is different in terms of how their vascular disease often presents. And many times this schematic doesn't give it a great example here, but often if you have narrowing here, you may actually see very small caliber of this part of the aorta. It doesn't always go back to that normal size. It can often remain very narrowed and tapered, and Dr. Fairman will touch more on that as well. So blood pressure monitoring guidelines, I think, are one of the most important things that I can stress as a pediatric nephrologist. So the American Academy of Pediatrics has a 2017 guideline on managing and screening hypertension in general pediatrics. Routine blood pressure screening, as Jess and Dan mentioned, is actually only recommended for otherwise healthy children starting at age 3. However, there are a list of high-risk diagnoses where children under the age of 3 should begin screening at all physician appointments or doctor's appointments. And you can imagine, as you all know, in the first 3 years of life, there's many doctor's appointments and many opportunities to have blood pressure checked, and this can often be missed. There are many barriers to obtaining blood pressure in young children, and so sometimes either it's not done or it's underdiagnosed or missed, such as was with Mila's case. The high-risk conditions I have on the next slide here for your reference, and I also have some handouts at the end of the talk that people can take to reference that have the table of high-risk conditions as well as proper technique for how to check blood pressure, especially in smaller children when it may be more challenging. 5% of children, as Jess and Dan also mentioned, have a high-risk condition that puts them at higher risk for high blood pressure. So again, you need to start screening at the time of diagnosis and not wait until 3 years of age. This is the list of high-risk conditions per the AAP guideline, and I just call out here, this is where NF1 really falls under other systemic illnesses, so things that affect the whole body but also can lead to high blood pressure, and there are a whole host of other genetic diseases that do this as well. So how should a child specifically with NF1 be screened? Just to reiterate, checked at all doctor's visits, starting at diagnosis, regardless of their age. If the reading is elevated, it should be repeated when they're calm, manually auscultated, meaning the provider should put a stethoscope on their arm, pump up the blood pressure cuff themselves, and not rely necessarily on the automatic machines that we often rely on, and then rechecked at a very short follow-up date. Getting the number right is really one of the most important pieces. So proper blood pressure technique is one of the ways that we can help to try to really capture kids appropriately and get them into the right providers. So for all children, you want to attempt the blood pressure on the right upper arm underneath any clothing, so on the bare arm. This is a common misconception. We've all been to the doctor. How many times does your doctor just put it over your shirt or your big sweatshirt? Those are actually very inaccurate blood pressure readings. You want to make sure that the correct cuff size is chosen for your child. So the cuff width should cover at least 2/3 of the length from the elbow up through the shoulder, and then the length of the bladder within the cuff should cover about 80% of the arm circumference. Too small can overestimate, and too large can underestimate blood pressure. For children less than 3 or who have challenges or difficulty cooperating, which is very common, supine or semi-supine position, as noted here, can really help to calm the child and provide a better way to get a blood pressure reading. For kids who are older than 3 or even younger kids who can participate, seated in a chair with their arm resting at the level of the heart, typically on a table, feet hanging down straight or flat on the floor if they reach, is the proper way to check a blood pressure. And as Dan and Jess said, the right arm is always the arm that should be checked. These are the parent cards that we actually give out at all of the CHOP centers through the Magical Mila Foundation, and I have many today, so please at the end come and take some, that just reviews these technique reminders for how to get optimal blood pressures in children less than 3, but can be applied, of course, to older children as well. I also have some posters and other clinical handouts that you guys can feel free to take at the end. So again, tips for successfully obtaining a blood pressure: disturb the child as little as possible, use lots of distraction, whatever works, take the blood pressure first before you do anything else so as not to upset them by other reasons, and then again, right arm under the clothing, and ensure that the cuff is on properly and is the correct size. So you've checked the blood pressure. How do we interpret these readings? I think this is one of the other most important takeaways that I hope I can convey today, is that for kids above the age of 13, it's relatively simple. We all know that typical blood pressure readings for the most part in adults should be less than 120/80, and that's the same for children less than over the age of 13. So it's equal to adults. So if your child has a blood pressure of 110/60s, you're like, great, that's normal. I know that's normal for me. That's normal for a kid older than 13. But in children less than 13, blood pressure in the 110/60s can actually be very abnormal, because blood pressure is determined based on your age, based on your sex, and based on your height. And so for children under the age of 13, that cutoff varies across the ages and across the heights and genders. So it's really important in younger children to ensure that the reading that is ultimately being seen actually falls within the expected range for your child. And one of the easiest ways to do this is a table that's also available in that 2017 American Academy of Pediatrics guideline. This is on the conservative side. It uses the shortest children across ages 1 to 12, but essentially gives you the 90th percentile, or that top cutoff, for every age group by gender. And so, sure, if your child's not the 5th percentile, but they're the 95th percentile, these numbers may vary by a few points, maybe 2 to 3, but this is a really nice kind of just quick and easy way to say, my 7-year-old boy should be like 106/68 and they were getting 118/72, that's too high, no matter if they're the 95th percentile or the 5th percentile. So it's a way as, the parent to also, and the caregiver to really kind of double check that things aren't being overlooked. And I just want to point out here that this QR code here is a link to the 2017 AAP guidelines for your reference, and we can distribute that as well at the end. So we've done all the screening. Ultimately, your child's blood pressure is high. Now what? So what your primary care provider can do once an elevated blood pressure is established, they can obtain 4-extremity blood pressure readings, and this is helpful in certain diagnoses, such as certain forms of mid-aortic syndrome, where the blood pressure may actually be normal in the legs or even in the left arm, but high in the right arm. And so that can be a useful piece of information as we are working toward referral and further evaluation. They can consider getting a urinalysis if it is easy to obtain. So kids who are toilet trained or older, it is not imperative prior. It will probably be done with the nephrologist regardless. They can also consider obtaining an early screening kidney ultrasound. This looks at the kidney tissue, the kidney size, and also can notice any sort of kind of surrounding potential tumors, masses, things that may be compressing the kidney as a first pass screening. And then they should refer to a local pediatric nephrologist. Urgency is really determined by the degree of blood pressure elevation. And so if you have stage 2, which is the highest category, it should really be a stat referral within a few weeks. Elevated or stage 1 requires really just routine referral. And then if your child has symptoms and stage 2 hypertension for their age and size, that requires an urgent ED evaluation. And what are symptoms? They can be really challenging to pick apart in small kids, babies, kids who are nonverbal. It may be irritability, it may be significant lethargy or inability, they're sleeping a lot more than typical, they're not able to be awoken to eat, or they're not eating as well. There can be associated significant vomiting. In kids who are more verbal, they may report headaches, vision changes, chest pain, difficulty breathing. So all of these things are important to just consider if your child especially does have higher blood pressure readings. So what will the pediatric nephrologist do? First and foremost, we will take everything that has been done and evaluated thus far at the pediatrician and ultimately establish a diagnosis of hypertension. And then we will perform likely additional screening, and that can vary depending on each child and their presentation. We'll often include kidney function testing, metanephrines, which are the hormones released by the pheochromocytoma specific tumors. We may do renin and aldosterone, which are hormones released by the kidney that regulate blood pressure. Thyroid hormone can impact blood pressure, and then additionally some additional advanced imaging, which most commonly starts with a Doppler ultrasound, so an ultrasound looking at the blood vessels specifically to the kidneys. It's not the most specific nor sensitive test for picking up renal vascular anomalies, and so oftentimes we'll also go to a CT or a CAT scan that uses an IV contrast to look specifically at the blood vessels to the kidneys. And then concurrently, we may start a medication because really, I think a big takeaway of treatment of hypertension is that medication management happens in parallel with diagnostic evaluation depending on the height of the blood pressure. And so many times we will start blood pressure medications while we are doing the diagnostic evaluation if the child has stage 1 or stage 2 hypertension. Intervention is then discussed and evaluated for option as we identify the underlying cause. So for renal vascular hypertension, which will be kind of the focus of the second part of this talk, we will referral to a comprehensive renal vascular program is really important because it is typically a team of nephrologists as well as vascular or interventional radiology experts who can provide either less invasive or more invasive options for intervention with kind kind of the ultimate goal of correction or cure, and the ultimate goal to lessen or eventually come off of blood pressure medications altogether. Pheochromocytoma, as well as other renal parenchymal compression from other tumors, would be tumor removal, chemotherapy, whatever it might be, as additionally indicated. So key takeaways: blood pressure screening is really of utmost importance. Often blood pressure is asymptomatic, and the only way to pick it up is by doing routine screening. Technique is extremely important, so advocating as much as you can for your children or children with high-risk conditions is really helpful in ensuring that blood pressures are being obtained accurately, and then partner with your pediatrician as well to ensure that regular and accurate BP readings are being obtained for your child. So now I'm just going to hand it over to Dr. Fairman, who is the head of our pediatric vascular surgery program, to talk about surgical and interventional options for kids with renal vascular hypertension.
Thank you so much for the opportunity to talk here. It's really an honor. I seem to have lost my voice a little bit on the travels from Philadelphia, so I apologize. But as a little bit of background, I'm a vascular surgeon. I operate on both adults and children. And on the pediatric side, I'm the director of pediatric vascular surgery at CHOP. And one of the things I'm most proud of is about 4 years ago, we started a comprehensive pediatric vascular surgery program there, one of the few centers in the world. And one of the things we focus on is in kids with renal vascular hypertension. As Dr. Mazza just mentioned, a lot of those children are NF kids. Here's a just 30,000 foot view of what we'll talk about today. When a patient comes to me, we look at different anatomic presentations that could be causing their renal vascular hypertension. I want to talk a lot today about the indications for surgical repair, choosing an intervention, and then talking about expectations for the patient and family post-operatively. And longitudinal follow-up is really important to highlight, because really after I operate on these patients, they are a patient for life, and we have to follow them routinely. I'm going to go through a couple examples of pathologies we see in NF1 patients with aortic disease. The first I'm going to talk about is mid-aortic syndrome, which has been mentioned a couple times before in the previous talk. And really that describes a narrowing of the aorta, which can also be called a coarctation. This coarctation can occur in NF patients in a variety of places on the aorta. So as you can see here, you have a narrowing above the kidney arteries. These are the kidney arteries in this patient. You could also have narrowings up higher towards the heart, so coarctations in the thoracic aorta. Along with mid-aortic syndrome, patients can also concomitantly have a disease in their arteries to their kidneys or to their bowel or towards their liver. Here is a patient with mid-aortic syndrome, so narrowing of the aorta right at the level of the kidney arteries. This patient also had an aneurysm and severe renal artery stenosis bilaterally. Just illustrating really the complexity and variety of presentations in these patients. Patients can also present with isolated narrowings of their renal artery, as in this patient right here. And patients with NF can also present with aneurysmal disease, so abnormal dilation of the arteries. And it ranges in complexity and presentation. As you can see in this first picture, this patient had a variety of aneurysms in the visceral segment of her aorta, or it can really be isolated to the kidneys, as in these patients. Depending how they present in the specific anatomy, they can present in a lot of different ways. So you could have medical refractory hypertension. You could have an acute hypertensive complications, such as problems with the left side of their heart, like acute heart failure, or that can even back up to the lungs, causing pulmonary edema. In patients with mid-aortic syndrome, so severe narrowing of their aorta, sometimes this could limit blood flow to their lower extremities, and they can get pain with ambulation and what we call claudication. Some patients really present with more generalized symptoms like failure to thrive, or they could have a lack of growth. If patients have narrowing to the arteries to their bowel, which is very common, they could have pain with eating. Fortunately, that's very uncommon, and typically the patients are asymptomatic. And for patients with aneurysms, there is a low risk, but not a zero risk of those patients having a rupture if the aneurysm gets big enough, and obviously they can present very sick and in shock. My typical indications for surgical repair are listed here. Typically, if we're talking about mid-aortic syndrome or patients with narrowings to the arteries to their kidney, these are patients by the time they're seeing me, oops, go back there. These are patients, when they see me, usually are on 3 to 4 medications, and that's what we call medical refractory hypertension. In rare cases, they could have also signs of end organ failure, like heart failure. Their kidneys may not grow, depending on where the exact nature of the disease is. And they could also have results in renal insufficiency. And then again, in very rare cases, if there's narrowing to the arteries to things like the bowel, they could have pain with eating and failure to thrive. And I also mentioned that the patients in very severe cases could have pain in their legs with mid-aortic syndrome, especially when they're walking or exercising. And now I'm going to break down how we approach treating each of these different pathologies. I'll start with mid-aortic syndrome. This is the classic way we treat mid-aortic syndrome. So if there's a narrowing in this segment of the aorta, I typically will bypass around it with an artificial graft. And this provides really 2 benefits. One is to offload the pressure on that segment of the coarctation is providing on the left side of the heart over time. And then it could also help relieve the severe renin release of the kidney, which is driving a lot of the hypertension in the first place. I think it's very important to highlight that this is really a surgical disease. People do use minimally invasive procedures like stents or balloons to treat this, but in my opinion, the most durable repair is with a surgical bypass. Many patients come to see us and they say, are there interventions that are more minimally invasive that can provide some treatment for the pathology? And the answer is yes in a certain patient population. For example, patients with a very isolated narrowing of their kidney artery, like in this patient here, can be excellent candidates for something called a balloon angioplasty or a minimally invasive procedure. This is particularly true in very young patients where you may not want to jump to a big operation to start. And sometimes this can be very durable, and sometimes it just does not last as long. It depends on the patient. Other patients present with narrowings in their renal arteries that are not as surgically accessible, and they also can be excellent candidates for a minimally invasive approach like a balloon angioplasty, as seen in this patient here. You definitely have to be careful about how aggressive you're doing these type of minimally invasive approaches, because in some cases, if you're too aggressive, you can cause an injury to the artery like this, making an open surgical repair much more challenging. And now, if we're beyond the point of saying that you're not really a minimally invasive candidate, how do we fix, for example, narrowings to the kidney arteries? The first would be something called a renal artery bypass, where we can excise through an incision on your abdomen or on your flank a portion of the unhealthy artery that's causing high blood pressure, and use either another artery from your pelvis to create a new artery to the kidney so that it's not narrowed anymore, and that's called a bypass. When you see very complex renal artery disease that's not as amenable to doing a straightforward bypass, my typical algorithm is actually to auto-transplant the kidney. And what that entails is actually removing the kidney through an incision in the abdomen, taking it to a sterile back table, reconfiguring the arteries in a way that is allowing the blood flow to not be impacted by the initial narrowing. And then I actually put the kidney back into the pelvis a little lower down so that it's no longer in the same position it was in. And in my opinion, this is the best operation for the most complex renal artery disease that we see. And I'll provide a couple pictures here. So these are different patients with NF who have seen us and have, presented with what I call the most complex renal artery disease. So you can have aneurysms close to the kidney like this, and with narrowing of the artery as well. Again, another very complex aneurysm to the left kidney that's close to the left kidney. And then you have patients with multiple renal arteries involved that have both aneurysms and narrowing. All these would be very challenging just to do a surgical bypass on, and therefore I proceeded with auto-transplanting them. And when I say, again, auto-transplanting, we actually remove the kidney initially from the patient, put it onto a back table, and then we can reconstruct the artery so that it is going to be implanted onto to an artery in the pelvis, where it is healthy, no longer narrowed, and even in patients who also have an aneurysm, we can fix that aneurysm as well. And here's a patient with 3 renal arteries involved, all with severe narrowing. Again, a patient I wouldn't have been able to technically surgical bypass, but with auto-transplantation, we were able to salvage all 3 of those renal arteries and even 2 of the renal veins that this patient had. So it's a really nice operation to fix a very complex problem. I think it's really important to highlight post-operative expectations for patients. That's one of the most common questions patients ask when they come to see us and we're discussing surgery. The length of stay is a very common question, and the answer is it depends on what they're coming in for and how complex their presentation is. In general, if we're doing an auto-transplant or an aortic bypass, I typically say 2 to 5 days in the ICU. Again, it's different for every patient. And then typically another 2 to 5 days on the step-down floor once they're outside the ICU. I would say 95% of our patients go to the ICU initially outside the operating room after we're done our reconstruction, and that's really to monitor blood pressure, heart rate, urine output, and other signs of organ function after our surgery. I will say we also have a specific anesthesia team that works with all these patients that's very skilled in cardiovascular anesthesia, and I think that's critical. I tell patients that pain is, and their families, pain is very, very normal after the surgery, but we manage it with pain medicines. Sometimes they have a little pain pump after the surgery that can help them. I really like to push the patients to get out of bed and walking as early as possible to help promote recovery, to get you out of the ICU as fast as possible. And it can also help prevent things like pneumonia, fever, and blood clots. Here's some other very common things I talk to families about. It's very common to feel fatigued and have reduced stamina for weeks after the operation. Usually that lasts about a month. It's also very typical to have fluctuations in blood pressure and continued need for medications in the initial post-operative period. It's particularly with patients with the most complex disease. The blood pressure is all over the place in the first month after the surgery, very typical. We talked a little bit about incisional pain that typically goes away after about a month and gets better even after the first week after surgery. Anorexia or having a reduced appetite is also very typical in the first month after surgery. I tell patients you can do a gradual return to activity after the first 2 weeks of the operation, but to avoid heavy lifting for the first 2 months to prevent hernia formation around my incision. It's also really important to, even if you're not hungry, to try to maintain nutritional status, whether it be through protein shakes, et cetera, and to stay hydrated after the surgery. Once you get out of the hospital, longitudinal follow-up is key. And we're really lucky to have our renovascular hypertension clinic, which is a multidisciplinary clinic, including nephrology, vascular surgery, and also interventional radiology, and we follow these patients long term. Here's a typical imaging protocol that we have for our patients. Again, it differs depending on what we're doing for a procedure, but typically I do imaging before they leave the hospital, 1 month after the hospital, 6 months, and then 1 year post-operatively. And if everything's looking okay, usually we image them at least 1-2 times a year. For any type of bypass, auto-transplantation, and even with aneurysm repairs, I typically put the patients on aspirin for life, very safe medication, unless you have some contraindications that we would discuss. And then in terms of expectations of blood pressure control, it's hard to answer that for every patient. So some patients who have very straightforward focal narrowing of the renal arteries, you can expect hopefully over the first year, very significant improvement in blood pressure control. But for patients like I've shown in previous slides that have really complex disease, it could take over a year to see the max benefit, and it may not be that you come off all medications, but the hope is that we get you down in the majority of medications. So in conclusion, patients with NF really are best managed if they present with vascular pathologies by a multidisciplinary team of experts, which should include, in my opinion, nephrology, surgery, interventional radiology. Durable and definitive management of aortic and visceral arterial disease really relies primarily on open surgical methods, although there are definitely some patients who do benefit from a minimally invasive approach. And then longitudinal routine follow-up is really key for patients undergoing vascular reconstruction. It really becomes a lifelong patient. Thank you.
So we're going to take time for questions now. I just highlighted here the website links for our multidisciplinary renovascular hypertension clinic as well as our BP under 3 program. And then I think we would be doing Jess and Dan Rumberg a disservice if we just didn't show how much their work has improved blood pressure screening at CHOP over the last 7 years. So at baseline, we were only blood pressure screening 1.7% of high-risk children in the CHOP primary care network, and now we are screening and getting appropriate blood pressures on at least, as of when this data was pulled, upwards of 85 to 90% of children with high-risk conditions. So this work has made a tremendous impact on kids with high risk for hypertension long-term.
I don't know if this might, oh, perfect. So I'm going to cut the line and ask a question that I think is really important because I know how subspecialized what you guys do, and that was an amazing talk. But if I am a patient that's either a child or an adult and my institution doesn't have a vascular surgeon or a multidisciplinary clinic that is aware of both NF1 and the renovascular complications, how do I navigate finding one of those institutions or navigate a second opinion?
Yeah, that's a great question. How you navigate it is tricky. There are really 3 centers that offer pediatric expertise in a multidisciplinary fashion across the country, and that's ourselves at CHOP as well as Michigan and Duke. And Boston, actually I would lie, Boston also has a program. We have websites. Otherwise, it's often a lot of word of mouth, families or providers who have seen the work that we're doing across the country and will refer patients in that way. Through our website, there is a universal referral form, which can be utilized by both providers as well as families. So word of mouth is one of the ways that we are able to get kids in for evaluation and second opinion. There are some insurance barriers that our team works really hard to work through to make sure that every child is getting the appropriate specialized care. Do you have anything else, Alex?
No, I think that's exactly right. And they're the only 2 centers who do auto transplantation, I would say, are Boston and CHOP. But those 4 centers, you'll get great care.
Hi there. Thanks for your talk. I am a parent of a 23-year-old NF1 patient. About 10 years ago, he was diagnosed with renal artery stenosis. They wanted to wait to do stents to let him grow. In the meantime, he was put on clonidine and Abilify for other issues, which lowered the blood pressure. We've moved, we're getting set up with new nephrology and had an ultrasound. Do those medicines, I know that they lower the blood pressure, but do they actually do anything to this stenosis?
Yeah, it's a great question. So there's really no data out there that any of the blood pressure medications that we have or use routinely have any true impact on the narrowing itself. It would be a big area for future research to understand how to essentially, turn off that overgrowth that's happening within the vessels, but none of the blood pressure medications that we use directly target the stenosis itself, which is why medication management plus often interventional options are really the standard of care to try to create longer term, more durable results and the ability to actually come off of blood pressure medication. Absolutely.
Hi, I'm Kristen. I'm the mom of a 22-year-old child with NF1, a grown adult now with NF1, and has just transitioned to adult care. So she's had heart rate issues and blood pressure issues. They ultimately diagnosed her with orthostatic hypotension, and she did some tilt table, and basically we've just been bounced back and forth between neurology and cardiology as to whether she should go on medication or not. I guess I'm just curious, obviously it's hard with each one of us in our own stories, you're not trying to diagnose or anything, but should she be seeing a nephrologist? She sees a lot and we've had great care. She's been to NIH, she's at WashU now, knowledgeable people about NF1, but for whatever reason, nephrology's never been mentioned, so I'm like, are we missing a link here?
Yeah, it's a great question. It's one of the biggest differences between the pediatric and the adult world, primarily with regard to hypertension management. So most hypertension in pediatrics is managed by nephrologists, with rare exception, opposite in the adult world. I think that if you have the right team, it's very possible that, they could look for ensuring that there's no renal vascular causes of the hypertension specifically. But some of those etiologies I talked about, like pheochromocytoma, can also raise the heart rate. So they would be important things to rule out. So I think, even a one-time visit with a nephrologist can always be of benefit, because there may be things they're thinking of that a cardiologist or a neurologist just may not be as aware of, especially within this smaller, more unique population.
Great, thank you so much.
Absolutely.
Hi, I'm Herb Sarnoff, also a parent of a child with NF1. Can you describe if there's any CNS-related impacts of the cardiovascular phenotype in NF1? Are there things that we should be looking for in the brain related?
Yeah, it's a great question. So in NF1 specifically, there is not as high of a known association of vascular abnormalities in the brain as there are with other forms of renovascular hypertension. So primarily, we don't do routine brain imaging screening for kids with NF1, though that being said, most children with NF1 are getting brain imaging for other reasons, and so you would pick up if there are vascular anomalies going to the head and neck or within the cerebral vasculature. You may pick those up on that imaging, though the association is not as well described as it is with other forms of renovascular hypertension, such as fibromuscular dysplasia, where we look at the head and neck in all of those patients.
Thank you.
Yep. Thank you again very much for having us. Pleasure to be here.
So now I'm going to welcome Dr. Taman O to the stage, who is a neurosurgeon and is going to speak about scoliosis management, which is another common manifestation that we can see in individuals with neurofibromatosis. So I'll welcome him to the stage.
All right, well, good morning, everyone. My name is Taman O. I am a professor of neurosurgery at Columbia and Cornell New York Presbyterian Hospitals. And I'm really excited to be talking to you today about one of the most common manifestations that we see in terms of the skeletal manifestations in our patients with NF1, which is scoliosis. These are my disclosures, which have no relevance to this particular talk. So I just wanted to start off by saying that, as a neurosurgeon, I see patients who have both NF1 and NF2. And I would say that by far and large, the most common reason I see patients is for scoliosis. And scoliosis is a very common finding that we see in our patients who have NF1. It accounts for nearly 2 to 3% of all of the pediatric scoliosis that we see, and up to 60% of patients who have NF1 do develop scoliosis. But how do we get from these genetic alterations that we see and know about to these skeletal manifestations? Well, as it turns out, neurofibromatosis is a gene that's broadly expressed in the chondrocytes, which are in the cartilaginous growth plates, as well as the osteoblasts and osteoclasts, which are cells that are involved in bone formation and bone breakdown. And so these are cells that you can imagine exist throughout the entire skeletal system, and this is why you can sometimes see other dysplastic features such as tibial bowing, congenital pseudoarthrosis, or sphenoid wing dysplasia. Now, when we're talking about scoliosis, what are we really talking about, right? The word itself is derived from the Latin term for twisting, and that's exactly what happens to the spine. The spine isn't just bending from side to side, it's actually physically twisting and rotating out of alignment. The vast majority of the scoliosis that we see occur in what we call the coronal plane, where you're looking at either the front or the back of the patient, and any curve that's larger than 10 degrees is defined as scoliosis. The second type of curve we sometimes see, it's a little bit rarer, are abnormalities in the sagittal plane when we're looking at patients from the side. And this occurs where the spine is essentially bending forward across the fulcrum, and this is called kyphoscoliosis. Now, looking at x-rays, this is something that can be sometimes difficult to tell because x-rays are two-dimensional images, but I really want to impress upon you that scoliosis really is a three-dimensional issue. And in NF1, scoliosis and its progression is primarily driven by skeletal dysplasia, which causes there to be an uneven growth between the left and the right sides of the spine, as well as poor bone quality or osteoporosis. And that rotation and twisting that I just mentioned, this is what our families and our patients notice first, because sometimes it manifests as either one of the shoulders are higher than the other. Maybe there's a prominence of one of the scapulas or the lower back. Sometimes the trunk can shift left to right, or a combination of all of the above. And so when patients are screened for scoliosis, we first start with the physical exam, and we follow that up with an x-ray. And these days, we really have specialized x-ray technology that administers 1/80th the standard dose of radiation. And this really has reduced our risk of imparting unnecessary radiation. And in terms of measurement, what we do is measure something called the Cobb angle, and you're looking at the two most tilted vertebrae, and you're measuring the angle between the two. And what's really interesting about scoliosis in NF1 is that it comes in two different flavors, and this distinction is absolutely critical. The first variation is what's known as non-dystrophic scoliosis, and these are the curves that are fairly mild. They appear very similar to adolescent idiopathic scoliosis, which is by far and away the most common type of scoliosis we see in our pediatric patients. And interestingly, there is a chance that the non-dystrophic scoliosis will modulate to what's known as a dystrophic scoliosis, and this is a much more aggressive variant. And we know that the younger the age of the patient, the higher the likelihood of this modulation to occur. And as far as I'm concerned, and many others in the audience, dystrophic scoliosis is a completely different type of scoliosis altogether. These curves are thought to mainly result from not only bone dysplasia, but pathologies that occur within the spinal cord that erode the surrounding bone. So you may notice on your radiology report something called dural ectasias or vertebral scalloping, and these are some things that you should look out for mostly on MRI. On x-rays, classic findings may include things like penciling of the ribs, wedging of the vertebral bodies, or sharp angulation in the curves. And all in all, what these features share in common is that the quality of the bone is very poor and has a very difficult time providing structural support for the growing spine. And just to illustrate this difference and show you how remarkable of a difference this is, on the left here, you see a patient who is someone who has a non-dystrophic curve. On the other hand, the second patient is someone who does have a dystrophic scoliosis, and as you can see, it's much more pronounced, and the spine is completely twisted to the point where it's almost in an S shape. Now, when we take a closer look at patients who have dystrophic scoliosis, we can immediately tell that the anatomy here is very, very different. The structure here that I've highlighted for you in red is known as the pedicle, and this is an important structure for us as spine surgeons because this is where we place our instrumentation during spine surgery. And as you can appreciate here, this pedicle is very thin and it's tiny and it's wispy, and this is very different from what a normal pedicle should look like, which is what I've shown here in the image on the bottom right there. And in NF1, the bone just doesn't behave in a normal way and has essentially eroded away. So threading in a screw into this very narrow channel often poses significant technical challenges. CT scans can also help us identify something known as rib dislocation, which occurs in about a quarter of our patients with dystrophic NF. And as you can appreciate here in this patient's images, at around the thoracic 10, thoracic 11 level, there's this piece of bone that's heading into the spinal canal, and this is the rib. Normally, this entire space highlighted in red should be free of any bone, but you can clearly see here that the rib is encroaching into the spinal canal. And if you look at the MRI, you can appreciate the spinal cord itself here highlighted in green. And in this particular case, thankfully, while the rib does touch the spinal cord, the cord itself does not look like it's under pressure or being injured directly by the rib being there. We often get an MRI in our patients with dystrophic scoliosis to really round out the complement of spinal imaging. MRI is really best for evaluating soft tissues and assessing the status of the spinal cord itself. And in NF1, very helpful to identify any plexiform neurofibromas that may affect our surgical planning. And again, it helps us visualize the scalloping phenomena and dural ectasias and helps us get a better understanding of what the risks of surgery would involve, because with these dural ectasias, there's a higher risk for encountering something called a spinal fluid leak after spinal surgery. So when we're talking first about non-dystrophic scoliosis, these are patients who come in and are managed very algorithmically. If you have a curve that's less than 10 degrees, we don't consider that to be true scoliosis, but we call that spinal asymmetry. And this is the kind of curve that you really have to squint in order to be able to see on x-rays. It's not a curve that needs any treatment. Observation is perfectly reasonable for these patients, but I do start recommending and thinking about vitamin D and calcium supplementation just to be able to enhance bone strength, especially because we know that many of our patients with NF1 do have low bone mineral density. Now, curves in the 10 to 20 degree range, they're treated primarily with physical therapy. I think there's a huge role for physical therapy for curves in this range. And there's the standard physical therapy that really focuses on working on core strength, flexibility, range of motion. But recently, there's been more of a push to adopt what's called Schroth physical therapy, or pediatric scoliosis-specific exercises. And there's a lot of data that's starting to come out of Europe that's really showing that the scoliosis-specific physical therapy actually does help to correct, or at least partially correct, some of the scoliosis. Curves in the 20 to 45 degree range, this is when we start talking about bracing. And as you can see here, these braces, they come in many different flavors, but one of the unifying themes here is that they look quite uncomfortable. But unfortunately, that's kind of the point, because if you can't get enough correction forces, the spine is not going to be able to respond appropriately. And these are just a list of different types of braces that your orthotist, if you're seeing an orthotist, may recommend, and it depends on the individual needs of each patient. So bracing is difficult. Oftentimes, one of the most common questions that I get is bracing worth all this time, investment, and effort? And the current guidelines for bracing come from this paper known as the BRACE trial, and in short, the answer is yes. Right? In this study, they took a group of kids, they either observed them or they braced them, and the endpoint was trying to prevent that curve from progressing to 50 degrees. And this trial was so successful that it actually ended early because the kids who were treated with bracing clearly had a much better outcome, right? About 75% of the patients who had braced were able to avoid progression of their scoliosis to 50 degrees, whereas in the observation cohort, it was less than half of those patients. And ultimately, this is our goal. If you can keep that curve stable, keep it below 50 degrees, that's a patient that can potentially avoid having a fusion surgery. And so, yes, Obviously, bracing sounds really, really great on paper, but I'll be the first to tell you it's much easier said than done. It does require a lot of commitment because these braces do need to stay on until the patient has completed their skeletal growth. In general, we do aim to achieve about 30 to 50% correction of the scoliosis with the brace, and if the patient is not demonstrating a significant response, they may require additional adjustments. The data is also very clear that the longer you can wear the brace, the better the results. But because we often find difficulties with being compliant with the brace, what I typically recommend patients is to aim small and miss small. So what that means is you start with nighttime bracing and then just keep checking in see how things are going. If the curve is stable and the patient is tolerating the brace, maybe you can stay the course. But if that curve is progressing, that's when you have to have a serious conversation about increasing the amount of time spent in the brace. Now, when we're talking about curves in the 45 to 50 degree range, surgery is really the treatment of choice here. And this is not just a magic number that we came up with. Back in the early 1980s, when we did not have really great treatment options for these patients, we looked at a group of kids who had scoliosis and looked at what happens with their curves over time. And what we saw was that once these curves are about 45 to 50 degrees, these curves will continue to progress regardless of where the patient is in their skeletal growth or their skeletal maturity. And so what this means is that let's say you have a 16-year-old patient who comes in with a 50-degree curve. When that patient is 26, that's going to be a 60-degree curve. When that patient is 36, it's going to be a 70-degree curve. And a lot of the modern fusion data corroborates a lot of these findings as well. This is a study out of Hong Kong that looked at a similar cohort of patients, but what they found was that about 60% of patients, if they have that 40 to 50 degree curve, they'll still experience progression by an average of about 1.5 degrees per year. And so what I find can be really helpful when having this discussion and conversation with patients is trying to understand that specific patient's risk for scoliosis progression. And the two biggest risk factors are really the size of the curve at time of presentation and the stage of skeletal growth. So if you have a young growing patient who has a very large curve, that's the type of patient that I would counsel heavily towards surgery more than surveillance or non-surgical intervention. Once we hit that 45 to 50 degree range, I do advocate for surgery. I rarely insist on it apart from certain circumstances, but there's really many good reasons why patients should be counseled towards intervention at this stage. The first reason is that you're taking a more proactive than a reactive approach. We know that this is a curve that's going to progress, and addressing it while it's still manageable in the 50 to 70 degree range as opposed to 80 to 90 degrees is just a much better proposition in terms of the outcomes, the morbidity, and the complications. If you have this 80 to 90 degree curve, that's a curve that's too rigid to get perfectly straight. So the patient may still have lingering issues with shoulder imbalance or truncal asymmetry and be very unhappy with the results. So intervening earlier can also give us sometimes an opportunity to actually do a much smaller surgery as opposed to doing a bigger, longer fusion in a stiffer and older spine. And again, don't wait too long and let that curve get out of control. If you wait too long, you do risk the spine reaching this end-stage disease state. And again, there's a significant risk and complication profile when addressing curves of this magnitude. Scoliosis can also impact quality of life. Nearly half of patients experience some form of back pain. Most kids obviously love to be active. Many of them enjoy and participate in sports. And realistically, once curves start reaching that 70 to 80 degree range, there's a significant impact on the ability of the lungs to function as well. And in our pediatric population, I think it's becoming more and more obvious that we need to be very, very cognizant about the effects that this diagnosis can have on the patient's mental health and well-being. So what this group showed was that almost a third of patients are affected psychologically from their diagnosis. And recently, the HARM study group looked at two different groups of patients with scoliosis, those who had surgery and those who did not. And these groups were matched in terms of both their age as well as the size of their curves. And the patients who had surgery showed significant improvement in satisfaction, self-image, and mental health, although the follow-up was fairly short at 2 years. And so when patients do commit to undergoing surgical correction, the gold standard surgery that we perform is called a posterior spinal fusion. And the way that the surgery works is, the analogy I like to make is to think of either making concrete or building a house. The screws and the rods are not the bulk of the surgery itself. What the screws and the rods do is they provide a scaffold or the structure, and then on top of that, we pour a mixture of bone putty, the patient's own bone, which hardens over time and eventually merges the instrumentation to the patient's natural spine. That's why it's called a fusion surgery. And this is a tried and true technique. It's been refined over 30 years now, and it consistently provides predictable correction and durable, great long-term outcomes. Now, those are the rules that apply for the non-dystrophic scoliosis, but we think about dystrophic scoliosis very differently. Again, this is the type that happens much younger in much younger patients, and it's really not a question of if, but when they will progress. So the goal here sometimes is to actually do a fusion surgery as early as possible, and some even advocate for doing surgery even if the absolute size of the curve is fairly modest, because again, we know the expected natural history of these curves. Bracing, casting, unfortunately, is not a great option for these patients except as a temporizing tactic, and this is a little bit complicated because it often requires us to have a very difficult and shared decision-making model because it's a complicated decision. A lot of our patients with dystrophic scoliosis have neurofibromas that need to be monitored, and by putting in fusion hardware, that can make surveillance of those lesions very difficult moving forward. We also need to be cognizant of dislocated ribs and decide whether these need to be addressed or not. And much of our understanding of what to do in these situations comes from our colleagues in China. So in general, if the rib dislocation is causing pressure on the spine or if the patient has neurologic deficits, the recommendation is to remove them. But if the patient is asymptomatic, it turns out it's actually safe to just leave them be. And the way we know this is because these ribs are they're dislocated. They're not physically attached to the spine. And so what happens is as you're moving that curve, the ribs actually stay and they move outwards from the spinal canal. And what you can see here is if you look at these three different levels in this patient who has rib dislocation, this is the pre-op scan. And then if you look at them post-operatively, the ribs are in a much more normal configuration. So if you do need to take the rib out, it's definitely feasible. It doesn't add that much morbidity to the surgery, but in general, I do try to avoid it whenever possible. Our patients with dystrophic scoliosis, the preparation is a little bit different. So once you commit to undergoing a fusion surgery, every step of the planning is geared towards optimizing safety of the surgery. And one of the ways we do this is by using traction. And this device that we place on the head is called a halo. This traction can be done over a period of about 4 to 6 weeks where we gradually attach weights, and that stretches the spine into a much better alignment. So just to give you an example of how powerful of a tool this is a 13-year-old young woman, mainly has back pain, has a 100-degree curve, neurologically intact, but you can see that the curve is very sharply angulated, which always raises a concern in our mind about the safety of doing any surgery. And over the course of 3 weeks, we added 30 pounds of traction, and the curve went down to about 80 degrees from 100, and the patient was able to successfully have a fusion surgery. This is just another example of how powerful of a tool this is. This is a patient who had a very stiff, rigid 120-degree curve, came in for about 6 weeks of halo traction. We got it down to 109 degrees, and this really may not seem like much, but I try to think of it in terms of marginal gains. Anything that we can do to make the surgery even a little bit safer and get us closer to the finish line is definitely worth pursuing. We also routinely use intraoperative navigation to help guide our screws into the best position possible. Like I said, these pedicles are sometimes very dysplastic, so sometimes you'll really only have one shot of placing that screw. And navigation certainly isn't perfect, there's limitations, but it does help minimize the risk of placing malpositioning the screws and instrumentation. Oftentimes, yes, as you can imagine, these are high-risk operations, but the results can be very rewarding. Spinal fusion is still the gold standard for our patients with dystrophic scoliosis, and this is a patient with an 11-year-old boy who came in all the way from Guatemala, has 100-degree scoliosis. He underwent traction for about 6 weeks, and that stretched it down to about 109 degrees. And we did a 2-stage surgery where we fused the spine and removed a piece of bone through a procedure known as a vertebral column resection, and he's been doing well post-operatively. Now, I've just spent 10 minutes extolling the virtues of fusion, but I just want to make sure you also understand that in our minds, the reality is that we also harbor many concerns over fusion. As is the case with anything, there's pros and cons with any decision that we make. So some of the factors to consider is that there's a cessation of growth over the areas that we're fusing. And maybe in an adolescent patient who's done with their growth, this is not such a big deal. But in a younger patient, this can really be a problem because it can affect the ways that their lungs develop. And patients who have this early fusion, typically before the age of 10, have worse pulmonary function compared to age-matched controls. And the higher you go up in the spine and the longer the constructs that you fuse, we see further decompensation of that lung function. We also know that by fusing the spine, there's a risk for accelerating the rate of disc degeneration or arthritis in any of the levels that haven't been fused. And this is a phenomenon that's been well documented. We do know that the adjacent levels, the facets, the discs, degenerate at a much quicker rate. And this effect is most prominent at L5-S1, which constitutes the base of the spine. And long term, while we generally believe patients do really well after fusion, there's some data that questions whether patients do have worse patient-reported outcomes in certain domains when compared to normal, healthy controls. So if we're not considering fusion, what options do we still have in our locker? The earliest option we have is something called casting, and it's very similar to how you get a cast in your arm for a broken arm. We apply this external cast over the body, and we put the spine in a much more anatomic alignment as that cast starts to set. The most common technique we use is known as metacasting, where the spine is elongated, derotated, and flexed as the cast starts to set. And generally, casting is very successful. It shows that the data shows that it can postpone surgery by about 3 years, and up to 70% of the patients are able to make it to 5 years without surgery. We've already discussed this, but bracing is certainly an option, particularly as a delay tactic. But one important point I wanted to make is that for dystrophic scoliosis, neither casting nor bracing have been shown to be particularly effective. So it's not something that I routinely offer. I do recommend it in select cases, but keep the expectations as reasonable as possible. There's also instrumented alternatives to the standard fusion surgery that we do. The first option is something called magic rods. These are rods that come with an internal magnetic component that you can physically lengthen over time. The benefit here is that you're really giving that patient time for their lungs and their spines to mature, let them get a little bit older. But the life cycle here is about 2 to 3 years. So at the end of that life cycle, you're talking about either replacing the rod or following it up with a definitive fusion surgery. So the downside here is that you're committing to 2 surgeries instead of a single surgery up front. And some kids do find the lengthening experience to be uncomfortable, and the rods can be quite expensive as well. This is just a slide that demonstrates how this rod extension works. We mark out the magnetic parts of the rod with this blue handle here, and then we'll input the settings into the control device, and this lengthens the rod by however length you desire. The other growth-friendly option that we have are traditional growing rods. And in this, we're placing 2 rods on either side of the spine. And as you can see here, they're connected with a side connector. And when we loosen one of the one set of screws on the connector, what happens is one rod is now loose while the other still remains anchored. And we'll apply distracting forces to physically lengthen that loose rod and then tighten the screws back down. This does require multiple planned reoperations about every 6 to 9 months. And there's a high complication rates with these, so because you're talking about putting in these rods with very limited fixation points, so they do hold a lot of stress and they are prone to fracturing. So just to close things out, I just wanted to take you through a case and kind of give you a sense of how I like to think about taking care of these patients who have NF1. This was a 21-year-old patient who was diagnosed with NF1 at 1 month of age, and he was gradually lost to follow-up for a period of time and came back when he was 21. When we saw him again, he was neurologically intact. He had never undergone any treatment for his scoliosis, and as you can see on his lateral bending films, it's a very rigid curve. So just to summarize here, we have a rigid double curve. These are both greater than 50 degrees, and this is a dystrophic scoliosis, right? When you look at all the features here, just going through them step by step, We don't really see vertebral scalloping. Again, sometimes this can be a little bit challenging to see on an X-ray, but the MRI did not show any scalloping. There's no rib penciling here. There is some spindling of the transverse process. There is wedging of the vertebral body. There is rotation of that vertebral body as well. No dural ectasia seen on the MRI. No paraspinal tumors. And yes, there are 2 focal short segmented curves. So the data is very clear. If you have 3 or more dystrophic features, because sometimes patients come in with dystrophic scoliosis, but maybe they only have 1 feature, maybe they only have 2 features, and that's a patient that we can reasonably watch closely before making a decision. But when you have 3 or more dystrophic features, that's highly predictive of needing surgery for correction. And this patient also does as you can see here on the sagittal X-rays, 87 degrees of kyphosis, and normal is anywhere between 35 to 45 degrees. So when it comes time to talking to this patient and counseling them, one of the common questions I get is, I feel fine, I don't have any back pain, do I really need the surgery? And in his particular case, we had a long discussion, and because of the dystrophic nature of the scoliosis, we did recommend surgery here. And of course, is there any role for bracing or some of the non-surgical options that we talked about? But this is a patient who's 21, right? They're done with their skeletal growth. Bracing, casting is not really applied here, and neither are the growth-friendly strategies. MRI just demonstrated that sometimes we see intraspinal pathologies that can contribute to scoliosis, like a Chiari malformation or a syrinx. We don't see any of that in this particular patient. Looking at their CT, at T9 and T10, there are 2 levels where we did find some rib dislocations. But again, this was a patient who was neurologically intact. So ultimately, they were fused from T2 to L3. As you can see here, normally you would expect to see 2 screws at every level of the spine. But here, in this case, we ran into the same issues we had with either the pedicles being absent or floating freely without being an anchor to the actual bones themselves. So we put in screws at each level that we reasonably could and attached what's known as these cross links. I don't know if you can see here, just to provide a little bit of extra reinforcement. And so thank you for your time. This is the team that I work with very closely over at Columbia and Cornell. Dr. Vitale and Dr. Roy are pediatric orthopedic surgeons who I often partner with in terms of doing these often complex surgeries. And Dr. Kaur is our neurologist who takes really excellent care of our patients with NF.
For questions.
Sorry, I didn't realize we had a Q&A to follow, so I'm happy to take any questions if there's any questions or concerns from the audience.
Hello. I'm the mother to a 6-year-old NF patient. He has dystrophic scoliosis. He's never had less than a 70-degree curve. He was diagnosed at 6 months old. He has not had surgery yet. Obviously, despite bracing, his curve has increased. He's currently at a 97, 85-degree Cobb angle with a 10-degree kyphosis. I'm just wondering, he also has multiple neck plexiform neurofibromas along the spine. What is your criteria for like a fusion versus like a rod placement, or at that age? Like, what would your recommendation be? Because part of the thing is that, he's so little, he's so condensed, they don't know really like what the correct thing to do right now, because obviously a fusion at this age, like he would still stay condensed in the chest cavity. So right. I'm just kind of wondering, like, what would your criteria be for like the rod placement versus a fusion at this age?
That's a great question. I wouldn't say I have any set criteria because it really depends on the individual patient.
Yeah.
Sometimes what I find to be helpful is actually getting x-rays of the hand, because even if the patient is, let's say, 8 or 9 years old, the x-rays give us a much clearer sense of where they are along their skeletal maturity curve. And sometimes you'd be surprised, patients are 8 or 9, but maybe they're a little bit more advanced than you think. Patients with NF1 also have short stature, which can complicate our understanding of whether their height is appropriate for their age, right? So I do use hand x-rays sometimes to provide just a little bit more information. My sense is if you're talking about a 97-degree curve, I assume he's also been evaluated by a pulmonologist.
Yes.
Yes.
He doesn't have any lung compression as of now, but he is under pulmonology care as well.
Got it. And so that definitely plays a factor in it as well. If a patient has poor lung function, poor PFTs, then I might start thinking about fusion for that kind of patient earlier on. Oftentimes, we also see that parts of the spine have already fused, right? Regardless of whether you brace or without any surgery. So having a comprehensive understanding is just really, there's a lot of variability to it. So
Yeah. Is rod placement until like a more appropriate age for fusion a possibility?
Absolutely.
Okay.
Absolutely. Yeah.
All right. Thank you so
Absolutely.
much.
Of course. Of course.
Your example, you spoke of the last person, 21-year-old. I'm just curious how it came about at 21. Was it all of a sudden symptoms? I have a 22-year-old who has been told he has this mild scoliosis, but we've never had an x-ray. I'm wondering if that should be a routine thing to be doing.
Mm-hmm. So for that particular patient, very old, and what I found was interesting was you're talking about dystrophic scoliosis in a patient who's 21, right? And all the data I've showed you shows that dystrophic scoliosis happens earlier. So he's a little bit of an anomaly. What ended up happening was he had a superficial plexiform neurofibroma, and so he underwent a total body MRI, and that total body MRI showed the scoliosis, so we followed it up with all of these other scans before making a treatment decision.
Hi, my question is similar to hers, but I have a 26-year-old daughter who had pectus excavatum, and during that they mentioned that she had scoliosis, but her pectus excavatum was so significant that that's what they focused on. At what point do we push for them to follow up with that? She was 17 when she had her surgery for that, and now she's 26. Her bars are all removed, but she still had the diagnosis of scoliosis. And she's adulting, so it's hard to get her to follow up with her NF treatment. But what should I tell her to tell her doctors?
So if a patient's reached adult age, can I ask what size of the curve is for her?
They said mild. I don't remember what the number was.
So there are a cohort of adult patients that I've been following for scoliosis who are not in the operative range. So it sounds very similar to your daughter. And I haven't seen those curves progress as long as they're less than 50 degrees. So I do follow them maybe once a year just to check in, make sure there's no new symptoms like back pain, make sure that the patient hasn't noticed any changes in their shoulder positions or anything that's really bothering them. But I think at this age, at 26, we're probably in the clear. Yeah.
Thank you.
Yeah.
I have a 9-year-old granddaughter with NF who has scoliosis. You were saying that mild scoliosis, physical therapy could be helpful. What about the 20 to 40% range where they're wearing a brace? Should they be in some sort of physical therapy also?
So you can mix physical therapy with bracing. The one challenge to that, however, is if the idea is for you to wear the brace 20, 21, 22 hours a day, it's very difficult to do physical therapy in the brace. So if a patient is definitely willing to do physical therapy on top of bracing, what I recommend is you can take off the brace for an hour, right, at most, or 2 hours as you're doing the physical therapy. But every other waking moment, you should try to have the brace on. So you can certainly combine the two, but just in my experience, I found it difficult to have the patients wear the brace and also participate in physical therapy.
And would you recommend combining the two?
I don't see any downside to it. I haven't seen any data that supports it, however.
Okay,
so,
thank
yeah.
you.
Hi, my husband is about to see a spine specialist. but he can't do an MRI because of his heart condition because he has a defibrillator. What do you recommend as a different type of imaging other than x-rays and CAT scans? Because we've done hundreds of those, and we're just trying to figure out where his pain's coming from other than scoliosis and the tumors, because they can't figure out what's going on with him.
Got it. Very tricky situation. There's something called a CT myelogram. Has that been offered?
No.
Okay. So a CT myelogram is a CT scan. You're doing a lumbar puncture and you're inserting contrast, and you're seeing where that contrast travels up in the spine. So the quality of the image is very, very good, and it essentially replicates the information that you would be obtaining from an MRI, so that might be something to consider.
And then, because his curvature is like into his heart and out from his back, do you recommend anything that we can go to the spine specialist with, like, can you look at this, or what do you recommend for something like that? I'm guessing you're mentioning that kyphosis, right, where the back is hunched a little bit forward. Is that what you're referring to? His is front forward a little bit, but his spine goes into his heart. It's really
I see.
weird.
I see. Okay.
Because it bulges out here, and then it does severely go into his heart.
I
Have
see.
you ever seen that, or what do you recommend?
Yes, so as that spine rotates and twists, it's very difficult to predict where that spine is going to go, right? So sometimes, yes, absolutely right, it goes anteriorly, right where the heart and the lungs are. There's nothing directly to do for that per se, apart from when you're talking about surgical planning, assuming, that's what the recommendation is, then sometimes that piece of bone is removed, not only for the correction, but to relieve pressure on some of the internal organs as well.
Awesome.
Yeah.
Thank you.
Of course.
I have a quick question about diagnosis. You're talking about patients who are 21 and just being diagnosed with scoliosis. And so our son, his providers understand the link between NF1 and scoliosis, so they do a check, but it just seems fairly cursory, like shirt off, touch his toes, stand back up, and that's basically it. Should there be something additionally done in general, or for him specifically?
Could I ask how old your son is?
He's 8.
He's 8. So my practice is to at least get one screening x-ray at some point, even if the physical exam is normal. And again, like I said, there's now x-rays where the radiation dose, initially that was a concern 5-10 years ago, but now we're able to control for that variable. Because you're right, especially in some of our patients who have larger bodies, if you have a curve that's balanced, they're not gonna know, right? Because you have like I showed you, 50-degree curve up here, 50-degree curve down here, and they're both in the opposite direction. So as far as the patient's concerned, shoulders are even, there's no physical signs of scoliosis. So I do typically get a screening x-ray and then follow up with exams after that.
Okay, thanks.
Okay. Oh, that was the last question? Okay. I'm so sorry. That was the last question.
All right, so it is my pleasure to introduce the last speaker of the session. Dr. Natanya Pollock is a pediatric endocrinologist at the Children's Hospital of Philadelphia and is going to talk today about understanding endocrine issues in NF1. So I'll welcome her to the stage.
It's a pleasure to be here today. So as Dr. Kotch mentioned, I'm Natanya Pollock. I'm a pediatric endocrinologist at the Children's Hospital of Philadelphia. And I also want to say that, Dr. O, you're welcome in our endocrine clinic if you're doing bone age hand x-rays in your own patients. So much appreciated. So I have no relevant disclosures. Before I begin today, I do want you to keep 3 things in mind as I move forward. So firstly, endocrine problems are prevalent in patients with NF1. Importantly, they are treatable, and then the outcomes are better if the endocrine condition is identified earlier and treatment can be started earlier. So at the Children's Hospital of Philadelphia, we have 2 subspecialty clinics within endocrinology where we may see patients with NF1 outside of our multidisciplinary NF1 clinic. These include the Neuroendocrine Center as well as the Endocrine Late Effects of Cancer Therapy Clinic. We also have an endocrinologist who sees patients as part of the multidisciplinary clinic. As we're learning, and many of you know, NF1 is a multi-system disease, and so having a group of providers who are familiar with the interactions between different organ systems and work very closely together is very important. So why do we care about the endocrine or hormone system in NF1? Why does this matter? Patients with NF1 are at higher risk of having an optic pathway glioma. These occur in the area of the hypothalamus and pituitary gland, which are shown with the pink you see in the image. And the hypothalamus and the pituitary are the major regulators of the hormonal system. And so if you have a tumor in that region, you are at risk of having hormone issues downstream of the hypothalamus and pituitary as well. Patients with NF1, though, also may have endocrine problems even in the absence of an OPG. And this may be due to the impact of neurofibromin, which is the gene product of NF1. It plays a big role in regulating the hormone release at the level of the hypothalamus and then can downstream lead to other endocrine problems as well. So how common are endocrine problems? There's a prevalence of about 23%. The prevalence is higher in patients with an OPG, so about 33% versus 17% in patients without an OPG. Endocrine problems range from issues with puberty, which is the most prevalent endocrine problem in patients with NF1 and an OPG, growth hormone deficiency, as well as some issues with thyroid and adrenal function. So there are many endocrine problems even outside of these listed today, but for purposes of time, we're going to focus on puberty, growth, including too little growth, and then actually also excess growth. We'll talk a little bit about bone health and hypothalamic obesity. I also want to mention, though, that especially in adulthood, there are endocrine tumors that occur in patients with NF1. Dr. Mazza mentioned earlier the presence of a FeO, which can lead to high blood pressure. And then also we are using MEK inhibitors to treat neurofibromas in patients with NF1. And there are potential endocrine manifestations or implications of using a MEK inhibitor. I'm not going to talk about those today, but I imagine, but I'm available for questions, and those are certainly areas of future research. So first, starting with puberty, it's important to understand what is normal puberty before you can really think about what is abnormal. And so early puberty, also known as precocious puberty, is defined as the onset of puberty before the age of 8 in girls and before the age of 9 in boys. The first sign of true puberty in girls is breast development. And so if a child is showing breast development prior to 8, that raises concern for precocious puberty and is worth an evaluation and referral to an endocrinologist. In boys, the first sign of puberty is testicular enlargement. That is not often something that parents notice. It's not really noted until you go to see the physician. And so I think really drives home the importance of regular testicular exams to identify pubertal onset in boys. I want to mention that pubic hair itself is not a sign of puberty. Pubic hair is driven by other hormones, such as androgens, that usually increase during the time of puberty, but can also increase prior to puberty. And so you don't have to be concerned or scared if the only sign that you're seeing is pubic hair and it is occurring early, but still very important for your child to be evaluated and seen by an endocrinologist. So children with NF1 have higher rates of precocious puberty compared to the general population. About 3 in 100 kids with NF1 will have precocious puberty. This usually occurs in the presence of an OPG, but again can occur even without. And so here's an example of what this looks like practically. So Dr. O mentioned the bone age x-ray. So when we see patients who are concerned about early puberty, we will get an x-ray of their hand. It gives us an idea of the skeletal maturation of their body relative to their actual age. And so here, the image on the left is an example of a plain x-ray film of the left hand in somebody who is 6 years and 4 months. And we look at the growth plates, or the spaces between each of the bones, and we compare them to reference images. It's a really rudimentary way to assess someone's skeletal maturity, but ultimately right now is the best we have, or the most easily accessible way to assess this right now. And so this child, who is 6 years and 4 months, their bone actually appears to be more similar to somebody who is 10 years. So when I compare their bone age between the two images you see on the right, the spaces between the bones in the hand are closer to a 10-year-old. And this is really important because that means this child has less time for growth. The growth plates being open is what allows somebody to grow taller, and then when you go through puberty, those growth plates close and somebody reaches their final height. And so in children who have early puberty, they grow during that period of time, they have a pubertal growth spurt. They may seem taller than their peers or you would expect, but then they end up finishing growing earlier than they otherwise would have, and their final adult height can be negatively impacted. The great thing about this is that it is treatable. There are two reasons we may treat early puberty, the growth being one of them, and then also having puberty occur earlier may have psychosocial implications depending on the actual age of onset. So if you have a child who has puberty very early and is expected to have menarche or their menstrual cycle at the age of 6, 7, 8, that is very early to potentially be dealing with it from a developmental standpoint, and so we'll often treat and pause puberty for those reasons. The treatment of precocious or early puberty is something called a gonadotropin-releasing hormone, or GnRH agonist. There are different ways that we can give this. One we may have heard of is Leuprolide or Lupron. This is an injection that's given at intervals of either 1, 3, or 6 months. There is also an option for an implant that goes on the inner arm called Hystrelin or Suprelin. It's a little bit bigger than the size of a quarter. And these medications, we monitor labs for efficacy, we monitor labs for side effects, but importantly, when you stop these medications, it's completely reversible. So when you stop the medication, puberty resumes as it otherwise would have. We're using these for temporary periods of time to pause puberty, but then it is very appropriate for somebody to go through puberty and have those sex steroid hormones, and so you ultimately have to stop the medication and you let puberty resume. There are some side effects of treatment directly related to the way that the medication works. There may be a temporary increase in puberty development for a few months that then stops. There may be a temporary increase in weight and blood pressure, less related to the medication itself and more due to you're suppressing the sex steroid hormones, and having adequate estrogen and testosterone helps with blood pressure and weight. This is, though, very important in patients with NF1 because, as we learned earlier today, and many of you probably already know, patients with NF1 have higher rates of high blood pressure. And then there may be some decrease in bone density during the time of treatment. This is not long term, and so once you stop treatment, patients regain the bone strength that you typically gain during the pubertal period. And long term, in adulthood, treatment with the GnRH agonist itself does not lead to decreased bone strength. There's a lot of question as to what puberty does to neurofibromas, and the evidence behind puberty and plexiform neurofibromas is clear. There are two studies that have looked at this, one at CHOP and one at the National Cancer Institute, NCI. They followed patients who were going through puberty over periods of time and measured the overall tumor burden, tumor volume, and there was not a significant increase in tumor size and tumor burden during the period of puberty. And so the puberty hormones themselves do not appear to increase the size of the plexiform neurofibromas. However, the impact of puberty hormones on cutaneous neurofibromas is a little bit more nuanced. Cutaneous neurofibromas typically appear around the age of puberty and increase in size and number as you get older, and also increase during pregnancy. And the clinical studies, however, have shown conflicting data. So in a survey, patients self-reported their change in cutaneous neurofibromas during pregnancy, and the majority of women noted that their cutaneous neurofibromas increased in size, and then they also had new growth. However, when patients in a separate study were followed and their tumor size was actually measured by their providers and the research team, there was no difference in the size and burden in females who are pregnant compared to females who are not pregnant. So there's certainly other factors at play, not necessarily just the pubertal hormones or sex steroid hormones themselves. Similarly, in female patients who are on oral contraceptives, their tumors, they were asked how their tumor size changed while on therapy, and in those on combined hormonal contraceptives or progestin only, they did not report an increase in tumor size. So there's certainly a complex interplay between age, sex steroid hormones, and then also growth hormone, which does increase during puberty. And so now getting a little bit into growth, patients with NF1 are at risk of too little growth or short stature. And then there also may be something quite rare called growth hormone excess, which we'll talk about. So this bell curve here shows the distribution of heights in the normal population. So here, the middle line is with the z-score of 0, the majority of patients will fall along that line. They have an average height. And in the population, there are some patients who have a height that is taller than average, or a z-score between up to 2. And then patients who are short will fall on the left end of the curve with a negative z-score. Patients with NF1, by and large, will fall towards the left side of the curve, so shorter than average than the general population. This schematic here shows the machinery necessary for growth regulation. The hypothalamus and the pituitary are responsible for making growth hormone. Growth hormone signals to the liver to make growth factors, or IGF-1, and then IGF-1 acts directly at the growth plate to cause increased growth. And some children with NF1 don't make growth hormone. They have growth hormone deficiency, and that is a common and treatable cause of short stature. However, there are other reasons that patients with NF1 can have short stature besides growth hormone deficiency, and a lot of it we actually don't fully understand why. There may be some impact of neurofibromin on growth. In a mouse study where the mice had neurofibromin knockout, so you removed the NF1 gene and the neurofibromin product, the mice with the knockout gene had smaller anterior pituitaries than those who were wild type. The anterior pituitary is the part of the pituitary gland that makes growth hormone and many other hormones. And then the mice with knockout NF1 also grew to be much smaller than the mice that were wild type. And so there seems to be, again, some direct impact of neurofibromin on growth itself. As I mentioned, growth hormone deficiency can cause short stature. This is only, though, in a minority of patients with NF1. Patients with NF1 may also have chronic conditions. We learned about hypertension. If it causes overall inflammation, that certain patients are sick, can certainly cause short stature. Patients may also be on stimulant medication to help with some of the ADHD and other learning differences. And stimulants can lead to short stature even in the absence of appetite suppression. And then we learned earlier today also about skeletal abnormalities. And so while skeletal abnormalities like pseudoarthrosis or scoliosis do not impact the machinery necessary for growth, they certainly, if substantial, can impact the overall stature. So I mentioned that patients with NF1 are also at risk of growing too fast. And so if we see a patient who is growing quickly, one of the first things we evaluate for is early puberty, because if you have early puberty, you can have an early growth spurt that is not expected. And so you could really just have growth excess due to that. But you can also have growth excess from just making too much growth hormone. This happens exclusively in the setting of an optic pathway glioma, where the optic pathway glioma, if infiltrating the hypothalamus, can lead to overproduction of growth hormone. This is a transient cause of growth excess in patients with NF1, and so and numbers are very small. So our evidence as to the natural progression of growth hormone excess in patients with NF1 is really limited to case reports and case series. But in patients who were identified to have growth hormone excess by physical exam, growth chart trajectory, and biochemical or lab testing, in patients who were not treated, some of the patients still had complete resolution without treatment. And this is very different than other causes of growth hormone excess outside of the NF1 population. Growth hormone excess can lead, however, to high blood sugar, diabetes, high blood pressure, cardiovascular disease. And so the decision to treat versus monitor is a nuanced decision in discussion with the parent, patient, provider together about risks and benefits. And here on the right, I just have a growth chart where you can see a female growth chart on the left and a male on the right. You can see the growth curve, and you can see the line is like straight upwards, and you really would never see that in somebody who is growing normally without growth hormone excess. And so just as the decision to treat growth hormone excess is a decision between the patient and provider, that is also the case when discussing treatment with growth hormone. So when we diagnose somebody with growth hormone deficiency, the treatment is with growth hormone. It is a daily injection under the skin. Patients are monitored every 3 months to make sure that they are growing taller and they are not having any side effects. Patients who have growth hormone deficiency in the general population and are treated with growth hormone typically have an increase in their height velocity in the first year of 10 centimeters per year. Patients with NF1 who are diagnosed with growth hormone deficiency and treated with growth hormone also have a beneficial response, but it is blunted relative to patients without NF1. And so in the first year of treatment, patients with NF1 can have up to about 7 centimeter per year growth, whereas pre-treatment height velocity is about 4 centimeters per growth. So it is certainly beneficial in improving height outcome. There are also other benefits of growth hormone treatment besides growth. Growth hormone is important for metabolism, bone health, cardiovascular health, and it has been shown in some studies to have cognitive benefits. One really big question, though, is the safety of growth hormone in patients with NF1 or other tumor predisposition syndromes. And we do not have great observational data. We don't have any randomized controlled trials looking at the safety and efficacy of growth hormone in patients with NF1. But in the limited studies that we do have, primarily the largest study was a study of 102 children with NF1 and growth hormone deficiency, followed for a median of about 3 years. Growth hormone treatment itself was well tolerated, and it did not increase the risk of tumor recurrence or increase in NF-related features than otherwise would have been expected from NF1 alone. And so there certainly are, risks and benefits of growth hormone treatment. And so the decision to treat in somebody with growth hormone deficiency, again, is requires a very thoughtful and close discussion between patient, parent, and provider, and also a discussion with the full multidisciplinary team who's caring for a patient with NF1. Now moving on to bone health. As Dr. O also mentioned, patients with NF1 have higher are at risk for lower bone mineral density. This graph here on the right shows the normal progression of bone mineral density over time. So in childhood, adolescence, and young adulthood, people accrue bone mass. Your bone strength, your bone mass is growing. You reach a peak in your late 20s, early 30s, and then as you get older, your bone strength and bone health declines. When we are looking at somebody's bone health, we compare them to the general population. So in older adults, we use something called a T-score, where we compare somebody's bone mineral density to what the bone mineral density would have been at peak age. And then in children and younger adults, we use something called a Z-score, where we compare the bone mineral density to somebody of the same sex and also the same age, and then we adjust for size. And so patients with NF1 have lower bone mineral density Z-scores compared to the general population. We measure the bone mineral density using a DEXA, and this is really important because lower bone mineral density is associated with a higher risk of fracture. And I'm not talking you get into a car accident and you break a bone. It's from small falls or minor trauma, something that you would not otherwise expect to lead to a fracture. And so being aware of this is very important because there's certainly monitoring that you want to do and things that we can do to hopefully prevent this. This graph here just shows the bone mineral density at the lumbar spine, so that's LS2 to L4, the femoral neck, which is the hip, and the green line is the average. The red line is -2 Z-score, and so when you're below that, you're really worried about a high risk of fracture. The reason for low bone mineral density in NF1 is multifactorial. Patients with NF1 may be less physically active. Physical activity is important for bone strength. Patients with NF1 can have low levels of vitamin D, which is very important for bone strength. And they also may have reduced sun exposure, which is also important for vitamin D. And so seeing a bone health specialist or an endocrinologist with specific expertise in bone health is important. And things that you can do in the meantime are really recommendations that we say for everybody in the general population when thinking about bone health. And these, I think, are very practical recommendations. So firstly, adequate vitamin D supplementation. For any growing child and adult, I really recommend 1,000 to 2,000 units of cholecalciferol or vitamin D3. These are really standard supplement doses that you're really not at risk of overdosing. And so even before seeing a provider, these are doses that are commonly available over the counter you can start taking. If you are already on vitamin D supplementation, I think it is helpful at some point in time to get a vitamin D level check to know if your dose is adequate. There are certain patients who have profoundly low vitamin D levels that require high doses to sort of restore the vitamin D, and then you can switch to more standard maintenance dosing. It's important to get adequate calcium. Calcium is a building block of bone. It's great if you can get calcium through the diet. We absorb it very well, and when you do calcium through the diet, it's lower risk of kidney stones compared to calcium supplementation. But if you're not getting adequate calcium through the diet, then you can also take supplementation. The CDC provides a really good, CDC website has good dietary recommendations for calcium where it lists different foods and the calcium amount, and so you can see if you're getting adequate calcium that way. And then weight-bearing exercises are very important for bone strength. And I like to think about, the reason weight-bearing exercises are important is that your muscle is attached to bone, and when you're doing weight-bearing exercises, you're getting little micro tears in those muscles, and the bone has to respond by building bone mass. And so all of this together, again, recommendations for the general population as well. And now just briefly moving on to hypothalamic obesity. The hypothalamus regulates our energy expenditure and satiety. This is an area that is very challenging to treat. Patients with a tumor in the hypothalamic pituitary region are at risk of hypothalamic syndrome or obesity, but also patients with NF1 even outside of this, again, knowing the effect of neurofibromin on the hormone system at that level of the hypothalamus are at risk. There is a lot of emerging research and medications for treatment of hypothalamic obesity, and really prior to recently, this was just very challenging to treat because exercise and diet does not improve the obesity the way that it would in our typical causes of obesity. Here I list 3 different treatment options that are available today for hypothalamic obesity, including GLP-1 receptor agonists, GIP receptor agonists, setmelanotide. This is currently closed for recruitment, but is an ongoing phase 2 trial looking at efficacy in hypothalamic obesity. And then also phentermine and topiramate. This is actually actively recruiting at 2 sites, Seattle and the Children's Hospital of Philadelphia. This figure on the right shows the mean decrease percent BMI after treatment with setmelanotide over a period of 12 months. And you can see that all patients had a decrease in percent BMI change from baseline, some greater than others. But this is really quite promising since up until recently, hypothalamic obesity has been very difficult to treat. I am running out of time, so I think this slide is the big takeaway if you're going to take away anything from my presentation today. And these are things to watch out for, and just think red flags in your mind about when you want to be seeing an endocrinologist. So firstly, I mentioned the signs of early puberty. If you are concerned about growth patterns, so slowing down or falling off of a growth curve, fractures without a clear injury, and then also weight gain that does not respond to our typical measures. When you see, hopefully, we're seeing an endocrinologist, these are questions that you can ask or questions that you can ask your NF1 provider if not already seeing an endocrinologist and hopefully could be referred. How often should height and weight be checked? When should we do a bone mineral density scan or a DEXA? And then how often will you want to repeat? Are there certain blood tests that we need to be monitoring for the endocrine hormone system? And then what are things that we need to be looking out for that would bring us in sooner rather than waiting, every 6 months or every 1 year to be seen? And so again, endocrine problems in NF1 are prevalent, they are treatable. And then again, the outcomes are improved if identified and treated early. And so with that, I'll take any questions.
Hi there, I just wanted to start by saying thank you very much. That was a wonderful speech. So from an endocrinologist perspective, is there a suspected correlation between neurofibromatosis type 1 and endometriosis in women based on what we know about those shared hormonal sensitivities and pathways? And if so, because I know there are some hypotheses going around right now, is there any more rigorous research right now in an academic setting or within the current pharmaceutical pipelines to investigate that link more rigorously?
That is an excellent question. There are studies that have looked at the NF1 and endocrine or reproductive endocrine abnormalities in women. So there is thought to be a link with endometriosis, also an impact on like pregnancy outcomes. I will say, as a pediatric endocrinologist, I do not deal with this as routinely, and so I actually am probably not the best equipped to answer this specific question, but Dr. Wilson is giving a talk tomorrow on the impact of NF1 on contraception, fertility, and sort of, I would say, overall more women's health related outcomes. And so she may be a better person to answer that specifically in the emerging research. I apologize.
That's okay, but just from your knowledge, is it still just in like the very loose hypotheticals, or are we pretty sure?
Loose hypotheticals. I think that, like, as I mentioned even today, a lot of it is like, we think this is what's happening, but there's also a difference between what we're studying in vivo, so like mouse studies, and then what we actually see clinically, and a lot that is unknown. And so I think the best way for us to, for further research is to see what we're identifying clinically, and then go back and see what can we actually, identify and actually, from a link perspective. But loose hypothesis right now.
Okay. Thank you very much.
Yeah.
So I have a 5-year-old daughter with NF1. She has an optic pathway glioma. At age 4, she was diagnosed with precocious puberty and growth hormone excess. So she was doing 3 times a day injections for 3 months, and now she's on once a month injections. Her growth hormone has come down, but it's not controlled. From your knowledge, looking at long term, how long should we expect for her to be on injections for, and what does the future hold for her if we take her off of injections and for her growth?
It's a great question. And so firstly, the reason she was on the multiple day and then switched to the monthly, I imagine it was octreotide and lanreotide. We want to make sure we tolerate it well before switching to the longer acting. In studies that have of patients with NF1 and an OPG who had growth hormone excess, on average, patients are treated for about 1.5 to 2 years and then are able to come off. All of that being said, there are serious case reports and just clinician experience that even with treatment with the octreotide or lanreotide, we may not always see complete resolution or normalization of the growth factors and itself. And knowing that this is a transient process, it's led to a lot of question about, well, do we actually need to be treating? Can we monitor? Especially when diagnosed in the toddler age, there is a lot of clinician reported experience. I would say it's not published, but at one of our recent endocrine meetings, a lot of in the room, providers were talking, and we've said, we've monitored in the toddler period without treatment, and again, it still gets better in that same time frame. So it sounds like she's been on treatment for not quite that 2-year, but even though her growth factors have not, they've improved but not completely, normalized, I expect that too, and she should hopefully come off within the 2 or shortly after time period.
Thank you so much.
I have time for one more question. I'm so sorry. Thank you.
Hi, real quick. Well, this is sort of quick, but I'm going to try to make it quick. We have a son who is now turning 21 on Monday. He's been on MEK inhibitor for 11 years, doing very well. We thought we were out of the woods, and they did a bone scan from age 10 and now 20, and it was devastatingly low. So they've kind of ruled out it being MEK related, but they ran the the FGF23 levels, and it's very elevated. In terms of research with tumor excreting this, tumor osteomalacia, I think is the term, is there anything kind of in the works with research to understand if there's something associated with bone loss and that particular fibroblast growth factor 23?
So we know that, even outside of patients with NF1, we know that there is risk of decreased bone mineral density with abnormalities in FGF23, and there are targeted treatments in that setting. I am not familiar with those therapies being used in a clinical trial or a research setting with patients with NF1. But I think that you raise a good point. So I didn't mention this directly, but NF1, the neurofibromatosis gene, plays a role on regulating the bone cells. Dr. O had mentioned, like the chondrocytes, osteoclasts, osteoblasts, and those cells secrete FGF23. And so there's a link sort of indirectly with with FGF23 and neurofibromin, but ultimately, the treatment for low bone mineral density in somebody at that age is going to be treatment to build bone, and then also to decrease bone resorption. So like a bisphosphonate, I'm not sure if anything has been brought up, but bisphosphonate or medications like teriparatide to build bone. And that would be effective. We use that in patients with osteomalacia. We use it in patients with fibrous dysplasia and other abnormalities related to FGF23 and low bone mineral density. Okay. Thank you, everybody.